Let's go ahead and learn everything we need to know about TBI or traumatic brain injury for our nursing school courses and, of course, for the NCLEX. We're going to start with the pathophysiology. The pathophysiology of TBI or traumatic brain injury is where the patient sustains direct trauma to the skull, resulting in injury of the brain. And we're going to talk a lot about different injuries to the brain. Let's first start with primary versus secondary injuries. Primary injury is what happens as a direct result of the trauma to the brain, such as bleeding of the brain. Then we can also have secondary complications or secondary injury, which could be that because of the injury to the brain, now the patient becomes hypotensive or hypoxic or develops other problems. Those would be secondary injuries. A big part of our treatment goal is going to be to prevent secondary injuries if possible, which isn't always possible. Next, let's talk about the Monroe-Kelly doctrine. The Monroe-Kelly doctrine is an easy test question that you may often see, and it talks about the fact that within the skull, within the cranium, the cranial vault, we have three things. We have brain tissue, we have blood, and we have cerebrospinal fluid. The Monroe-Kelly doctrine teaches us that these three things must work in correlation with each other because if, let's say, the brain, which takes up roughly 80% of the skull, starts to swell, they end up with cerebral edema. Now the brain is taking up more than 80%. That means that the blood and cerebral spinal fluid will have to decrease in order to compensate and allow for that swelling. Next, let's talk about intracranial pressure. ICP, or intracranial pressure, is exactly what it sounds like. It's when we have an increased pressure inside the brain, almost always as a result of either a brain bleed or swelling of the brain. We're going to talk more about that in just a little bit. Next, let's talk about a concussion. In the signs and symptoms box, we have here, it's really not signs and symptoms, we have here really all the different types of TBIs. So let's start with the concussion, which is 90% of all TBIs. And concussion is often called a mild TBI. What is it? It's where a patient takes direct trauma to the brain, but the patient ends up with full recovery within 24 hours. The signs and symptoms are all reversible. The classic presentation is usually syncope, where they pass out. They might become nauseous, have a headache, things like that, but everything goes away and goes back to normal. That is a concussion. Next, we have a contusion. Contusion is more serious. Contusion is a bruising to the actual tissue of the brain, again, as a result of direct trauma to the skull. Then we have DAI, diffuse axonal injury. Diffuse axonal injury is where a patient takes trauma to the brain. Again, we can use the classic baseball bat to the head, and the actual brain tissue fibers, they end up, the word is shearing. They end up um, ripping apart, basically. And this has a terrible, terrible prognosis. These patients are often comatose for the rest of their life. But that's DAI, diffuse axonal injury. Next, we have different types of brain bleeds. We have an epidural bleed versus a subdural bleed. In both of these bleeds, the bleeding is occurring along the skull. The difference being epidural or subdural is it above between the skull and the dura mater, which is one of the layers of the meninges around your brain, or is it under that and more on the brain side? So is it on the skull side or the brain side of the dura? So that is an epidural or a subdural. A epidural bleed, the classic presentation, and this is a good NCLEX question to know, the classic presentation is the patient takes trauma to the head. They may or may not pass out and have a syncopal episode, but the classic presentation is they come back to full alert, fully conscious alert. You would think it's just a concussion, but then a few hours later, they're comatose or dead. That is the classic presentation of the epidural. That's what you may see on the NCLEX. As opposed to a subdural, which is where they have a slow brain bleed, and over there they have slow progressive over usually hours or a day or so, decreasing neurological status or increasing neurological symptoms. That's the difference between an epidural and subdural. Epidural has that, it's called lucid period, where the patient comes fully back, alert oriented. They seem like they're perfectly fine, but then they very rapidly decline, as opposed to subdural, which doesn't have that classic interval where they're perfectly fine, but rather they slowly go downhill. The last three things we have listed are intraparenchymal, subarachnoid hemorrhage, or intracerebral hemorrhage, are all bleeding within the brain tissues. Now, all of these can also be taught in the terms of a stroke, but we're talking here in terms of trauma. So all of these are different types of brain bleeds within trauma categories. Let's look over at diagnostics. For diagnostics, the classic way we diagnose a TBI is with a CAT scan of the head. Next, we can also use an MRI. And for diagnostics, we may also, not so much at the RN level, but the patients may be classified as having a mild, moderate, or severe traumatic brain injury. Let's look at the nursing assessment. There's a lot to go over. First, we have the GCS, which is the Glasgow Coma Scale or Glasgow Coma Score. Hopefully, by this point in nursing school, you're very familiar with that. If not, Bullet Point Nursing has a great video to cover this. But this goes from a scale of 3, which is what a dead person gets, to 15, which is hopefully all of us, fully alert and oriented, and anything in between. When we look at how a patient's categorized as a mild versus a moderate versus severe TBI, the most common classification is using the GCS. Mild, depending on the textbook, is going to be 13 to 15 or 14 to 15, is going to be considered mild. This one, you do have to know every textbook says that a severe TBI is where the patient has a GCS of 8 or less. 8 or less is a severe TBI. And somewhere in the middle of that is going to be your moderate TBIs. Next, let's look at increased ICP. We talked about this briefly of what is intracranial pressure. It's where we have extra pressure in the brain, usually as a result of bleeding or swelling. In these cases, we run the risk of a patient developing herniation, which is where the brain tissue literally starts to herniate. It starts to push out of the brain, usually through the brainstem, and starts to have very, very bad outcomes in that case. The normal ICP, I don't know if you'd have to know this at the RN level, but the normal ICP is 5 to 15. If a patient gets a ICP above 20, if you see that on a test question, that's a huge red flag for herniation. That's a big risk for herniation, where the patient's brain is going to get pushed outside of the skull, the cranial vault. Next, let's learn about pupils. When a patient has pupils, we can assess, not when a patient has pupils, we all have that, but when we're assessing pupils, we can use that to assess neurological status, specifically if a pupil is fixed and dilated. That's classically known as in slang as a blown pupil, a pupil that's fixed and dilated, and that's a really bad sign. Unlike if you already watched the stroke video, we know that the symptoms of, let's say, a left-sided stroke is going to be on the right side of the body. Pupils, it's still the same side. And that's a test question that students often get confused on. But if, let's say, a patient has a left-sided blown pupil, left-sided pupil fixed and dilated, that means there's bleeding on the left side of the brain. Next, let's look at Cushing's triad. Cushing's triad is a common thing that we test on in nursing school for presentation of TBIs. And Cushing's triad is 3 things. It's a widening pulse pressure. That means a growing gap between the systolic and the diastolic, also known as the systolic heading up and the diastolic heading down. That's part number 1 of the triad, of Cushing's triad. Part number 2 is bradycardia. And part number 3 is irregular respirations, such as Cheyne-Stokes respirations, if you remember that from respiratory videos. Now, if a patient has Cushing's triad, they're at huge risk for developing, that's a huge sign that they are developing increased ICP and heading towards a bad outcome. Next, we have posturing, another really bad sign that the patient's having a bad outcome. Posturing is where the patient goes into decorticate posturing or decerebrate posturing. Decorticate is where they just basically their arms curl up into what would be the fetal position, or decerebrate is where they just become sort of spread eagle, and that's a sign of poor neurological outcomes. If you know the GCS scale, those both score very low on the GCS score. Finally, the last 3, battle sign, raccoon eyes, and halo sign. Let's talk about each of those. Battle sign is where the patient has bleeding or hematoma, not bleeding, but a hematoma or ecchymosis behind the ears. Raccoon eyes is where the patient has periorbital ecchymosis, black and blue mark around the eyes. And both of those are signs of basilar skull fractures. Now, the big thing you have to know for testing purposes, if someone has either of these, battle sign or raccoon eyes, those are signs of basilar skull fractures. And if a patient does have those, you cannot put in any NG tubes or suction in the nose, anything like that, because if they have a basilar skull fracture, the tube might not be forced by the bones to go down the right direction. It might actually be able to go directly into the brain. And now if you Google images of the NG tube wrapped up in the brain, it's pretty cool, but very inappropriate, because those happen when nurses or providers put an NG tube in a patient that has a basilar skull fracture, because again, their structure may not be there to guide the tube down into the esophagus where it belongs, and it may end up going just twirling up inside the actual brain. Next, we have halo sign. If a patient does have any TBI, then if they have any bleeding coming out of the ears or nose, we always take a gauze and we dab it into the blood, and now we look at the blood. Halo sign, a positive halo sign, is where the blood on the gauze becomes a dot of red surrounded by a dot of yellow. That's a positive halo sign. That means that the blood that you just touched has cerebral spinal fluid in it, which means that there's been significant injury to the brain, that the patient's now leaking cerebral spinal fluid out of either the ears or the nose, wherever you assess. Next, let's look at the nursing priorities. Basically, over here, it's really simple. It's airway, breathing, circulation, disability, A, B, C, D. So we're going to monitor their airway, monitor their breathing, their circulation, their mental status. Good test question here. The number one most sensitive indicator for a patient's status on a TBI is going to be their mental status. The second we see that going down, we have a big problem. And again, the best way to assess this is with a GCS. You're going to be assessing that over and over and over again. The biggest thing in the treatment of a patient with a TBI, at least at the RN level, is preventing secondary injury. Don't ignore, don't fail to assess and notice if the patient develops hypertension, hypoxia, or anything that can cause secondary injuries. The treatment for these patients, first of all, a nursing intervention is going to be to keep the head of the bed at 30 degrees. Some textbooks say 45 degrees, so either one of those would be correct. But we want to keep the head of the bed at 30 to 45 degrees. We want her to do a really good job of monitoring their vitals and level of consciousness, like I just mentioned. The patient may be treated if they have cerebral edema. The treatment for that is to give them hypertonic solution, which is 3% normal saline, and or to give them not and usually or to give them mannitol, which serves the same purpose. Both of those work to pull the cerebral edema, that swelling, that extra fluid out of the brain tissue and into the blood. And once we get it in the blood can get it out of the brain skull. So again, the actual cranial vault won't have that increased swelling, which can result in herniation. Next, we have surgery may be the option in a patient having TBI. Last two things, client education. When you should educate them what their follow-up is, and short and long-term care. And this is going to vary widely. If it's a concussion, you want to tell them to just be monitoring it the next 24 hours, make sure that it don't get any worse. If it's DAI where they're in a coma, so it's going to vary widely based on what's going on with the TBI. And finally, complications. Known complications of a TBI, again, can vary widely, but the most common ones that you'd be tested on would be DI, which is diabetes insipidus, or SIADH. And one of those, the patient's holding on to way too much fluid, that's SIADH, or in DI, they're peeing out way too much fluid. Both of those are neuroregulated. So if a patient's having a TBI, that neuroregulation may go away and they may end up with these. Seizures can be one of the most common complications of a TBI is where patients develop seizures. And finally, herniation would be the most concerning complication of a TBI, where the patient's brain actually herniates out of the cranial vault. Hopefully that covered what you need to know for your RN Medsurg course. If you have any questions, please reach out. Hope you do great in class, and we'll see you in the next video.